I'm delighted to welcome you to our third and final for the moment in our series of rehabilitation webinars. And today, as you know, is going to take the form of a panel discussion covering some questions which you've probably seen before. The session is going to be chaired by Steve Broomfield, and I'm really happy to introduce our panelists. We have Lise Henderson, Jane Ramirez-Insco, Marette Ambler, and Angela Cordingley. So I think we have representatives from most professions, which is lovely to get the different viewpoints. The webinar will be recorded and it will be made available to people via a link afterwards. So just bear that in mind if you're happy to be recorded. I'm going to hand over now to Steve Broomfield, who's going to introduce the session, and I'm sure he'll tell you how he wants to deal with questions. Thank you, Steve. We can't wait to hear what's going to be said.
Great, thank you very much. Thanks, Helen. So I think probably the best thing in terms of questions, if people put things in the chat, and then I'll keep an eye on the chat and try and sort of inject questions as we go along rather than sort of wait to the end. I'm sure pretty much everyone on this meeting, certainly the panelists, have got a lot more knowledge of rehab than I have as a surgeon. So I'm hoping to bring some almost like a lay person's approach to this and let the panelists do the talking. I'm certainly hoping to learn a lot from this session. So I think if we kick off and perhaps I'll ask our panelists, a sort of introductory question was about therapy and the importance in children compared to adults and where we think that balance lies at the moment and perhaps where we're not getting it quite right at the moment. So in terms of the future, where we think that could change as our resources get more and more limited. And obviously we'll look into some more of these topics as we go through, but to start with, where do you think the balance lies at the moment between children and adults? So perhaps start with Jane.
Okay, thank you.
As a speech therapist.
Yeah, hi everybody. The balance. I think when I read that question, I thought, well, actually, they both need support from us. Just it's a different kind of support in each group, in adults and children. So in children, I think the role is still really important to be involved in direct assessment and monitoring. But I think there's a massive role for indirect support and doing things in a different way. And in Nottingham, we've always worked jointly with local professionals. And so we're a consultative model in Nottingham. But I think the added value that we bring from the implant programs is the differential diagnosis of what isn't to be expected for a child with a certain degree of hearing loss or a certain number of years post-implant. So I think that's really important for us to still be there in the mix. I think another area that we continue to focus on is trying to train those who have more regular contact with the children, so their local support professionals and their parents, and provide them with resources and monitoring tools to try and know where their children are going and what they're doing next, and to spot some red flags. So I think the type of our sort of rehabilitation and intervention can continue to change, given that we're going to probably have, increasing numbers to support across their lifespan. So for me, I think adults also need our support, but you didn't ask that, Steve, but that was part of the question, was should they have more or less support?
The theme of the question. I think there's quite a lot you said there that we can sort of unpick a little bit in a moment. Perhaps I'll just get some initial views from the others. Angela, perhaps you could give us your thoughts as a teacher of the deaf and where you think the adult-child sort of overlap comes.
Well, personally, I don't deal with the adults directly. Julie on the team, who I know has joined this, deals with the adults. So I can only speak really from the paediatric point of view. But I agree with Jane. I think it's empowering parents is much more of the role these days, of giving them the tools to do things for themselves. And I think particularly with the younger children, there are fewer Sure Start centres and things like that that again families support locally. It tends to be a teacher of the deaf if they're lucky, or the numbers of teachers of the deaf are going down, and that's a concern that we've discussed already within the team. And so it's how we can get input to local professionals to empower the children, the adults to advocate for their children and to know what to do with them, because I think that for me is a big area that is changing rapidly at the moment, and certainly with COVID and children not having been seen as much, we're getting a lot of children coming through who are behind where we would expect them to be because they've not had direct input, and that's nobody's fault, it's just a reality.
Thank you. So again, a lot to get into there just in that first answer. So I'll hear some thoughts from our other panelists, and then we'll go into some of that. So Mirette, I don't know if there's anything you want to sort of add to what's already been said there.
I too work with children. I guess my feeling is that I have worked with adults in the past, and I guess my feeling is that much of the intensive rehab in whatever format it seems to take, it feels like it's a little bit more focused on children and young people compared to adults. I don't know exactly what the offering is. I think that there are a lot of resources out there, but the feeling is that perhaps it is more more recipient-led for adults than it is for children. There's perhaps a little bit of steering, more so for children than for adults again. So if you can access those resources, if you're computer literate, if you've got a practicing partner, then as an adult you can take ownership of it and it can work very well, I think. But if you don't have access to those kinds of resources, I'm not sure how the gap can be filled, how the gap is filled for adults compared to children. Whereas whether it's a consultative model or an in-house model, there are external professionals who are routinely involved with the child, any of which ought to be able to signpost to additional resources. So I think it's a bit more of a challenge for adults.
And Lise, before we move on, any thoughts from you? I can't see you on my screen actually, but are you there?
Yes, I am here.
Oh, hi.
Yeah, I agree with everybody, because there's a bit of a bias here, which I think reflects the bias that there is in rehab, that we're all paediatric. And if you look at rehab teams across adult and paediatric services, the paediatric rehab teams are always much bigger than the adult rehab teams. So I think the balance has always been more towards children. But I think that the adults, considering I'm a paediatric therapist, the adults, I think, can lose out on an awful lot. When we talk at MDT, we have a shared MDT, and you talk about people's backgrounds and histories, and I sit thinking, who's going to do the rehab work? They're 75 and they live on their own, and I'm not suggesting you don't implant them, but you just think, who's going to do the rehab work with that person? Are they going to be able to use an app? Are they going to be able to get on a computer? I think there are more robust, as Mirette says, you can point people in the right direction. There are far more people involved with a paediatric patient than there are who can signpost. And I think that service isn't there for adults. But I would also say I'm really concerned about the dwindling support that there is in the local services for paediatrics. Yeah. I mean, some of the kids we work with now, if they're lucky, they get a term visit for somebody who's in the first year of implant use. Yeah. So if we're not doing it, I'm not sure who are we consulting with anymore, because there isn't anybody out there to be a consultative model to. It really worries me that support is dwindling on both adult and paediatric fronts.
Thank you. So I might pause it there on that note, because we'll certainly come back to that subject. But before we move on, I'd like just to talk a bit more about the adult side. So perhaps Jane, I'll pick on you here, because you deal with more the adult side. Do you feel that there's sufficient capacity as a speech therapist to support adults following cochlear implantation, or do you feel that that's funding, for example, is lacking in that area?
I think in Nottingham we've got it right with the adults, and we are the direct deliverers of care to those adult patients for their rehab. And what COVID has thrown us is a massive opportunity to involve their family. So we are seeing a lot of our adult patients on virtual appointments, and we can involve their son or daughter in London or their care home worker. You know, it's given us, and we involve the virtual interpreters at the same time. They can lip read us on a virtual appointment where they can't still lip read very easily in the clinic because we're wearing clear masks that have got glare from the window. So it's a lot easier on a virtual appointment. So it has given us the chance to support their rehab post implant in a way that we probably didn't have pre-COVID. So and I think to give you all hope, we've got quite a lot of savvy adults out there who have found ways of accessing information themselves or by asking the right questions. We've got 84-year-old women coming in with live transcribe apps on their phone, and they hold it up to us and say speak into my phone. So I think we're able to help those who don't know where to look for the support or what to use. And I think what we're able to do also is to help them know what they don't know or what they're fearful of. So a lot of them obviously don't carry a smartphone because they don't make phone calls, but for them to know that a smartphone is a computer and they can access all the apps and live captions and all the other other things that we all use our phones for, and not really to speak on it. I think that's a really important role for us at the moment. It could be that clinical assistants can take on some of this work under our direction. But again, in adults, I think given the aging population we're implanting, I think they do need to be seen because of the comorbidities that are going to need to be referred. They're going to need to be referred on for investigations. Increasingly we see people who are showing signs of dementia, and we'll see it in how their responses are changing with their implants, how they used to be able to access the sound and now they can hear it but they can't make sense of it, or they get to the point where they can't hear it at all, but we know the device is working. So I think I must be very lucky then that I'm able to see all ages, and I feel that the referral rate of adults is increasing, and that we have got the capacity at the moment to see the adults. What we're doing is just shortening the pathway, so that we're not seeing them. We're concentrating on the first 6 months.
And do you do that flexibly? So would you vary the amount of input depending on how well the patient is doing, or do you have a sort of standard approach initially and then sort of see how it goes?
Yeah, initially we have a standard pathway, so 6 contacts in the first year like we would with the children, but those who are doing extremely well, it may be that they don't need as many of those contacts, or they can have a sort of light touch contact. So again, talking about video consultations or email contact or whatever, rather than an appointment. So,
and do you think that as the population grows, you'll be able to continue to offer that level of support in those first few months, or would you streamline it further for adults who are really savvy, doing well audiologically, and perhaps don't need the support in quite the same way?
I think the way we'll go is for those who are savvy and who are doing quite well, who need a bit more guidance, we'll be using our associate clinical assistants under our direction, and we will concentrate on assessment phase and the first 6 months post implant.
Yeah. Okay, that's really interesting. And again, we'll come back to some of the things you mentioned there about COVID and how that's affected us all shortly. But we'll move back to the
chat, Steve. On the chat,
oh, I didn't
Julie's
see that.
put that that she does the adult caseload here, and they're noticing an increasing number of adults with additional needs, learning disabilities, low literacy, mental health needs, and they're needing much more support and input. And I think that's something that because we have a discrete adult and paediatric SLT team, they're working hard on that, the input with the elderly, with the dementia, as you were saying, and things like that. And we're looking at the additional needs at the moment as a development at the moment.
And also, I mean, we found, I don't know if you found this, Jane, that some adults now who are coming through with better hearing are also needing extra support. Is that something you found as well?
Yeah, I call them the stick or twist brigade, because they don't know when to take the jump. They some of them think, I'll manage with what I've got. I know it's not great, but I'm fearful of losing it. So obviously we talk to them quite carefully about hearing preservation, obviously different tools that we've now, the surgeons have now got, like AIM, to try and preserve that residual hearing. Also, they've usually got another ear that's going to be aidable, so they can have their contralateral hearing aid, and how those might work together. And steeply sloping losses, high frequency losses, we have to counsel them to say, you're probably not going to like it when you get access to the high frequencies, and it maybe takes you even longer than someone who has no hearing at the point where they're implanted. So I think that population is really interesting, and varied, and really have quite individual needs.
Yeah. And
again, I think that ski slope loss as well with the paediatrics, since the new criteria came in, we're getting a lot more coming in with that ski slope loss who've got really useful low frequency hearing, and how are they going to adapt to a cochlear implant? And do we need them to be aided beforehand? Because if you're aiding them, then they're going to lose some of that low frequency access. It's a really tricky one at the moment, something that we're looking at.
Yeah, that's really interesting. And in terms of the sort of structure of our services, I think all three of you, I know you all do peds, but the three of you who do mainly peds, all mentioned the sort of interaction between the base and the local support. That's something I'd like to ask you a bit more about, because it seems that there's a real lack of local support, not the people who are there, but the lack of enough people to do what we would like to be done for the children. What do you see being the future there? I mean, do you think that there's more we can do from the base, or do you think there just needs to be more local services out there for children? Maybe Lisa, I'll come to you first on that.
You've got a big checkbook, Steve.
Well, this is the problem, isn't it? This is exactly the problem.
Yeah, because things are getting worse, not better, and I can't see how things are going to get better in the next few years, unfortunately. But yeah, the numbers are dropping. I mean, they're still training teachers of the deaf and speech therapists, so I don't know why the numbers are dropping, whether it's because the population is increasing, but definitely local services are being spread thinner and thinner. I mean, we have a different model to Nottingham. We do direct intervention. We do, of course, we liaise with the local professionals as well, but we have a more direct, hands-on approach in our rehab programme. But it is very, very difficult because there's less and less, and more children going into local schools with very little support. You know, it's hard to find a resource base these days, and the resource bases are the children who have additional needs, not just their hearing loss. So maybe that's part of it, is that children are spread over a bigger geographical patch, and it's the same number of people trying to get into 4 schools a day instead of maybe getting into 1 school a day and seeing 4 kids in a resource base. But people are retiring and their jobs don't seem to be being filled at the same rate. That's a bit depressing, isn't it?
Is that same in Moret? Have you found the same?
Yes, I would say that we have many of the same difficulties. We operate a similar model to the one that operates in Manchester, where there's a front loading of sort of in-house intervention, or we do go out and we offer that locally for some of our further distant clinics, so families can come to a hub that's closer to them. But the people that I was working with when I first started, there aren't as many of them. The ones, exactly as Lisa described, the ones that have retired, they haven't all been replaced. And I think alongside that, with regard to the complexity, I think the range of complexity of children that I see now compared to when I first started, modern medicine has moved on as well. So you are seeing many more complex cases that you just wouldn't have seen 20 years ago. And with all that goes with that, I mean, it's great that they're here, and of those, some will be deaf, and so we're working with that. So when you go to the resource bases, those schools are filled with children with sometimes incredibly complex health needs or social communication needs. So we have children that have their own nurse all the time that they're in school, so that level of medical complexity. And then the other children who are in mainstream aren't necessarily getting the right kind of support because they're with a generalist SENCO or a TA, a support someone who doesn't necessarily have that same level of experience as you might have had in a typical resource base. So everybody's stretched because the resource bases are stretched. They're dealing with further complexity. The local schools are stretched because they're thinking about and dealing with things they haven't thought about before. And it just seems that there are fewer and fewer people to be able to engage with.
I think cochlear implants are partially responsible for that. I think there is, I'm not saying it's a correct perception, but a perception that kids with implants don't need the level of support. Kids with implants can go into mainstream school. Oh, you're implanting them at 1, they won't need any rehab support, you know? And for some kids, they need very little, but that's not most of our population, as Marette says, you know. The jury's out about what percentage it is, but it's roughly 40% of deaf kids have something else going on. But everyone seems to have forgotten that. But I think we're almost victims of our own success. I've sat in meetings where SENCOs will say, well, they won't need any support, will they? And why not? Oh, well, because they're having an implant. So I think it's not our fault, but I think it's a product of the successful young CI users, and some of them are phenomenal, but not all of them.
And Jane, can I bring you in? Do you find you're having to increasingly rely on other support workers and or parents to take on some of these rehab sort of roles that you would normally have done yourself, or you would have delegated to a local teacher of the deaf or speech therapist? Do you find you're having to more and more rely on parents and carers to do some of that work, or has that not been an issue?
Yeah, I think we always have done, actually. We try to support and work closely with those who have the most contact with the children. So if that's a key worker in a special school, thank goodness, because they don't get teachers of deaf support in most of the special schools I go into, then that's the person that I would work closely with. And in a mainstream school, if they've managed to wangle an EHCP to get some teaching assistant support or communication support worker support in the mainstream school, then that's the person that I will liaise closely with, alongside the parents, like Angela said. And again, I think COVID has given us that opportunity to remote into to sessions in school. So because we've had to do it over COVID, they're quite happy to carry that on, where they set up the laptop, they work with the child in a withdrawal setting, and you join them remotely, and it works. So I think it isn't, all is not lost in terms of empowering and training those who have the most contact, but it's more challenging now, isn't it? And
perhaps I'll bring
we do
Angela
need to
in.
look.
If I can bring Angela in here, because again, as a teacher of the deaf, I imagine you found the same thing, have you?
Yes, I think we run the same model as Nottingham, in the sense that we go out and do the outreach in the local areas. So we're working directly with staff and with parents in the homes, things like that. I think the support in schools has definitely changed, the amount of support some of the children get, and because EHCPs in some areas are now very difficult to get, then actually having an allocated person, set amount of money set aside for that child is still not available in the way that it used to be, and therefore that support is not. So I think it's even more important that we're getting out there and actually trying to support the staff within the schools with those children, because they're just not getting what they would have done previously and really what they need. And because we're implanting more children who have additional needs which weren't necessarily highlighted before they were implanted, because we're implanting them younger, because they've got a primary need of deafness as far as people see. If we then get the child that comes along that then gets a diagnosis of well, needs a diagnosis of ASD, trying to get that in place so that that becomes their primary need rather than the deafness is really difficult to do, particularly if they've got the status of being a deaf child. Then actually getting another need identified as their primary need is incredibly difficult.
Thank you. Can I just say as well, I'm struggling to see the chat here. So can I ask the panelists if you see anything in the chat that sort of catches your eye? I'm really sorry, I can't seem to find it here. So just moving on from what you said, where is the shortage? Do you think it's that we don't have funding for the posts, or is it that we don't have people who want to do this sort of role? Perhaps Angela, you can sort of carry on with that one. I don't know if you've got a handle on that. But if a job was advertised sort of tomorrow, would there be lots of people who are trained and keen to work in this area, or is it more that the funding isn't there for the roles, or a bit of both?
Well, all I can say is that the areas that we cover, we had 8 teachers of the deaf that in areas that we covered, and only 4 of those posts have been filled over the summer. So yeah, which is a concern. 2 of which are not going to be filled, have already been said, and then 2 I think is the recruitment issue. So I think also it's an ageing population in the teachers of the deaf as well. I think, I did it initial training and then straight into a year doing the teacher of the deaf training before I went into a school, and that option's not there now in the same way. It's more within house in order to get your qualifications and things like that. So I think there are two aspects of it. The way that the training's happening is great, that it's happening in schools and it's giving that direct support with the children, but also the number of people being trained is reduced.
Yeah. And Lise, does the same apply in speech therapy, would you say?
No, the government have just started an initiative, which I'm going to be on the receiving end of, because the hospital has signed us up. Apparently, physio, speech therapists and occupational, the government have dictated that we have to increase intake. So apparently the physiotherapy school at our hospital is increasing their intake by 100%. And the speech therapy courses are increasing by up to 50%. So we've basically been told we have to have student placements, which is fine. I have no problem with having student placements, but that's how I know that they're doing that. So I think they have finally cottoned on that it's not acceptable for people to have a 2-year wait to get a speech therapy assessment, because that is what's happening in most community clinics, be it you're hearing impaired or not.
That's across the board for speech therapy, not just implants,
yes.
presumably.
Yeah.
That's interesting. Well, hopefully that will have a knock-on effect in a few years to have.
Yes. Yeah.
Because if more students come with you, then they'll have more chance to be inspired to come into the field of implants, and which I don't doubt they will. Mirette, do you want to say something
Lise,
there?
I just wanted to sort of ask Lise actually if her understanding of the market for the job market for speech and language therapists is similar to the one that Angela described for teachers of the deaf. Is it the case that there are positions that people aren't applying to be filled, or is it actually that people aren't being replaced, that there isn't money for new posts?
No, there are jobs advertised. Not that I look, because I'm very happy where I am. I'm not leaving, but there are jobs.
We all do that, Lise. We all
only
do
to
that.
retire. That's where I'm going. But yeah, there are jobs out there.
Okay, that's interesting. Thank you.
And Mirette, maybe I could ask you as well about from the audiology side, because do you feel that there's local support, for example, hearing therapists? Do you think that there could be more local support from audiologists and hearing therapists for patients with implant? I suppose it's perhaps more of an adult question than paediatrics, but
That is more of an adult question, but I'm strongly inclined to say yes. I think that for me at the moment, where there's a gap, and I could imagine it would be similar with adults, is yes, there's lots of savvy and technically switched on people out there, but there are also a lot of people who are sort of dabbling on the fringes of how they use their technology. I have quite an expensive smartphone that I basically use to do WhatsApp and play Candy Crush or something. I'm not using it to its full potential, and I think there is a gap, particularly beyond the communication rehabilitation, which I absolutely don't want to diminish. There's a big gap with regard to all of this connectivity that is now available in these amazing bits of kit that that are on the outside. We've got the implant is marvelous, but it's ostensibly the same. It hasn't changed much over the last 10, 15 years. It's stronger and it's more reliable, and that's great. But that we can pair to our phones and our telly and all sorts of things kind of at the touch of a button is great. But which button? And it takes a lot. I spend a lot of time figuring out how to get somebody to be able to pair to their Xbox or whatever whatever gaming console they have. And without the bits of technology there, it's actually really quite challenging. And there's there's such a wide range of potential interactions. I think that alongside the communication gap, the communication support, there is a gap, an emerging gap for a new kind of support. I don't want to identify exactly who that ought to be, but there's definitely a need there, which I would be happy to fill if that were my primary role. But there's a lot to keep on top of there, a lot of specialist knowledge.
I'm smiling here because I hear exactly this from our audiologists, that patients will come to their switch on appointment and seem more concerned about linking to their Xbox than actually, or their iPhone, than actually learning to listen with the implant. Do you think there's a role for the implant companies here, or would you be sort of wary of that? And there's been a lot of sort of interest in them doing more of the sort of follow-up and support roles. Do you think that has a place?
I think that is that's good in theory. I think that if certainly the implant companies are keen to, it seems to me, have direct access to families, to recipients. My most recent experience of that was a family who had called the implant company because they were having connectivity issues, and then called us a little bit miffed because apparently we were saying, somehow having spoken to the implant company, she understood that we were saying that everybody needed an iPhone 13. And actually what she had been told was that it's that you need an operating system, iOS 13. And so that's talking to somebody in the implant company with the knowledge, misunderstanding it, and coming and feeding back to us something that wasn't quite right. And so there's
we've seen that a fair bit as well, to be fair.
Well, I'm glad it's not just, but that's where the personal touch or the direct communication, even if it's virtually, I think being able to have a communication at a pace that's right for the individual, and to be able to go back to that information and to go back to it again is helpful. So, and I would say a multi-channel approach is absolutely fine. We will regularly and routinely signpost families to the online videos. We've got a collection, and sometimes we'll find a new one. And so there's all sorts of ways that we can provide the service, and I wouldn't want to exclude the implant companies from that for no other reason than their production values are probably phenomenal compared to the YouTube videos we put together during lockdown. But if that were the only way, I'm pretty confident that there'd be quite a significant number of recipients and families who would fall through the gaps of that.
And I'll stick with you a moment just as an audiologist, because I'm interested in this connectivity question with implants generally, and particularly at the moment because of what's happening with hearing aids and the increase in sort of hearables, as they're called, technology, and over-the-counter aids, which are now shortly to be approved in the US. Do you think that's going to lead what happens with implants in terms of people demanding that same level of connectivity, and that potentially could put extra pressure on us to be up to speed with all these tech things as we move forward?
Yes, I think we're probably already there in many ways, because there's the issue to do with amplification and over-the-counter amplification, but every other person you walk past in the street is wearing some kind of connected hearing device, and then within the home there are devices that you can listen that are listening out for you to ask them something or other, and you can do that via your phone, you can do that via a smart speaker. So I feel in some ways that we're almost already there, and it's only a matter of time before more and more people start asking that. I worked in implants before, they were waterproof, and people say, well, why can't you swim in them? It's like, you can hear, this is supposed to be a really good thing. And now, and so the goalposts have been moved and moved and moved and moved. So absolutely, as a matter of course, people will want to be able to make their cochlear implant technology do what everybody else's acoustic wearable devices do.
Maybe one day there'll be an Apple cochlear implant processor that people can
maybe I can imagine it will be possibly not in my lifetime, but something like an implant will be an option of choice. People will be choosing to have implantable earpods or whatever, because then you can go swimming, you can have sound on all the time. People walk around in the world.
That's of course where I think ethically there's a big challenge, isn't there? Because we're moving from restoration of hearing into proper bionics, and do we want implants to do real-time translation, for example? Well, that sort of question is going to be an ethical challenge for us, I think, in future. Lisa, let's bring you back in then on the pediatric side with the tech issue. Do you find that is an equal issue, or do you think it's more of an adult?
Have you seen Marette's face? Marette knows what me and technology are like. I am the biggest dinosaur known to mankind. But yes, it is. It's absolutely, people come with their iPhone and they app on at first programming, and it's a big issue. And I think from my point of view, the good news is most of the parents are younger than me, and so they know how to download the app and connect it themselves. But yeah, people come and that's what they want. They want to have the same things that their friends in school can do. They want to be able to use a mobile phone. They want to have that connectivity. And I think it's part of what influences processor choice, I think, in parents more now than it ever used to be. When you're comparing manufacturers and how easily some connect and how easily some don't, it's definitely having an influence, I think.
It's interesting, and we could talk more about that, but let's move on slightly, I think. And previously someone mentioned when we were talking about maximizing our resources that we have, people were talking about different tools that they use. And this is something I'm really interested to ask you about, because whenever I go to meetings and I hear talks on these things, there seems to be some new tool that's come out that everyone's raving about, and then the next time I go, there's a different one. So perhaps I can ask you about sort of your favorite sort of assessment tools that you have for sort of assessing outcomes, really. And I guess particularly in children, we'll perhaps talk about children without additional needs first, because I appreciate it's a very different thing. But so for a child who doesn't have additional needs, who's had the cochlear implant, do you have what are your most favoured tools for assessing their sort of progress, their outcome? Obviously be for different ages as well. So perhaps start with Angela maybe for this one, if that's okay, and just give us an overview of what sort of things you're using at the moment in day-to-day practice.
Yeah, so we use names. Thank you, Jane. And
I was going to come to Jane first, but I thought I'll give everyone else a chance
probably.
to speak first, because Nottingham seems to have done quite a lot on these things every time I hear about them.
We also use the Medelia's battery for children who are that little bit older, and then those with additional needs will look at, again, Jane, we're using the early call, things like that to monitor progress. So I think probably we've got a very similar approach, the Nottingham team, and really, to be honest.
Jane, would you like to add to that? I mean,
yeah, it wasn't all my doing. I'd like to be able to claim it was, but it wasn't. I was just part of the team. So yeah, we do use names. So with your early implanted, those that look like they're following a normal path, really helpful in the first 3 years. Early call, really helpful with the children with additional cognitive difficulties. And obviously there's two parts to that, because there's the tolerance and wearing issues part of the early call, which is often the first problem, is trying to keep it on long enough for it to be useful to a child. And then obviously the other side of it is whether their progress is similar to their cognitive ability and their overall interaction ability. So yes, we do use those with those two populations. And two, I would just add the two new ones that we are trying to audit their use of, but of course COVID has thrown a spanner in the works. But Speech Towns to Talk is a tool that we've developed to try and replace the speech intelligibility rating, which wasn't devised for children born prelingually deaf. So Speech Towns to Talk is sort of based on they're going to develop speech following a normal pattern in the first 5 years. We think it works. So we want lots of teams to use it and see if it does do what it says on the tin. We think it's nice and simple. And the very early bit of that is something called a baby talk tracker, which is really useful in the first year. And in that first year also, and in the assessment phase, we've developed the BELL, which is baselines in early listening and language, which sits nicely with Baby Talk Tracker because it's looking for early steps of audition alongside early vocalization development. So they work really nicely together. And then where children have got established language, we're using a new set of text tracking resources. So it used to be called connected discourse tracking, and we've developed some new tools that hopefully will be useful with those older children who are maybe being implanted because their hearing levels meet new NICE guidance since 2019. And those who are in the mainstream classrooms expected to sit and listen to a teacher in year 4 talking about whatever subjects they're talking about. And we can use the text tracking to show that their tracking rate is 60 words a minute and the rest of the children in the class are about 100 words a minute. That's why they're tired. That's why they can't keep up. So I would say that's in the mix as well.
That's really interesting. And again, a lot we can sort of get into a bit there. But before we do, perhaps I'll come to Lise, because Lise, I know from my time in Manchester, and this was a long time ago now, your view on things like the SIR and the CAP and these things that are very crude measures. What are you using at the moment? What's your sort of approach?
We use language assessment, so formal language assessment. So we don't necessarily use the child's chronological age. We may use their hearing age. So things like the MacArthur Communicative Index, the preschool language scales is our main one because you can look at receptive and expressive language and track that over a year's period. So that we're looking at change and rate of progress. If you use the same assessment, hopefully you're getting to see the growth in that language because you're not jumping from one assessment to another. And that's partly because I think it's as Jane said, the discourse thing, which to say, this kid's managing to track at 60 words a minute and everybody else in the class is way more than that. I think it's having illustrative tools that if you take a language assessment into a classroom and say to a teacher, I know he's 4.5, but on a standardized language assessment, he's functioning at 20 months. That is why he is not coping in your classroom, because this is the level of instruction he can follow. I think it's important to compare them. I know they're not hearing because that's why they've got an implant, but most of these children are now in a mainstream classroom and they are being compared by teachers and by parents with the hearing peers in their classroom. And so being able to use a standardized language assessment saying, this is why you can't have the same expectation. And sometimes you can, because sometimes they are age appropriate. But so, and we obviously talk about day slogging, and we have things like the ASSE for speech perception, and but because we have a different rehab model, we're not doing as much on the monitoring at the points we see them because we're seeing them fortnightly. So we're sort of gathering data about these children all the time because we're having one-to-one sessions with them and their children, not always face-to-face anymore. We are absolutely learning how to embrace video calls and things like that. But actually, when we polled our parents at the end of COVID, most of them wanted to go back to face-to-face appointments. I think they find there's a role and a use for the video calls, but they preferred and felt they got more out of the session if it was a face-to-face one. So we don't monitor in the same way because we're seeing them more regularly.
Yeah. And I'm already picking up there's a lot of different approaches or different tools at least used to measure the same things. Is that true across the board? Is that true internationally? is because I think one of the problems we have with surgery is that everyone uses different ways to measure their outcomes and so on, and then it's therefore hard to compare, whether it be in research or just on, you know, centre to centre. Do you feel that's the same sort of internationally? Everyone's using different tools, and it's hard to then compare like for like.
Yeah, absolutely. Yeah, and
is
it's why
there
things like
any
the
sort of
CAP and the
move
SIR are
towards
still
consensus?
around. Well, part of the problem is if you do something like a standardised language assessment, you have to go and standardise it on children with normal hearing, and that's a huge task. And if you, so we used to work out in Malta, we used to support the Maltese implant programme, and they'd love to be able to have a standardised language assessment. But there's such a small population, they just can't gather enough data to be able to standardise anything. You know, the PLS came from America, so they've got really big numbers. So I think if you're in English speaking countries, you've got a bit of a better chance of maybe being able to get some consensus. But it's really hard to standardize things when people are speaking so many different languages. How do
you cope when you have a child whose English is not their first language? Do you have to adapt?
With the difficulty, yeah. That's the hard thing. I mean, and again, we still most of the time would use something like the preschool language scales because these children are going into a mainstream.
Oh, I've just lost you slightly there.
You're still giving information to a classroom where they're speaking English. So we still would use English speaking language tools, but we understand the impact of English not being their first language. But it's again about that information that we're sharing with teachers and parents. Parents need to understand the progress rates that their children are making. If you're 5 when you get an implant, we're seeing a huge increase, I don't know if you all are, of children coming to this country late. So my average age of implantation has shot up again because we're getting really late implanted you know, it's almost going back to the days when I first started working here, when you got implants as 5-year-olds. It's much harder work.
Lots of nods there. Jane, can I ask you, when you're developing a tool, how much do you have to take into account children whose English is not their first language?
To be honest, we validated them on English. We don't have that. We don't have that expertise to apply it to a different language. So, you know, some of the tools, say like the names, has been translated into different languages. So it was under advanced bionics until quite recently, and several countries wanted to translate it for their uses, but we wouldn't be able to say that it was actually validated in whichever language it's been translated into. So we have to stick with what we know really, and then obviously use the same provisos as Lisa was talking about. We do know that, you know, we've got many different spoken languages in the children we support, and we want the parents to speak their home language first when their children are implanted at a young age. And we also use the preschool language scales, but obviously we can't use it on everybody. So our data pot is a bit scant at the moment with COVID, not being able to do it online. I know there were some adaptations recommended to use PLS online. We chose not to do that. So we are going back now to outreach work and face-to-face for more of our appointments with children, but we don't have sufficient tools in the world of deafness to monitor the progress. So in terms of different languages, I don't know whether there are very many that could be used. I mean, maybe in one other language, but it's not mainly the main language of where we all live. You know, we've all got different other main languages in the cities.
Yeah. Marette, I'm going to come to you next. Again, just move on just slightly, although we could talk much longer about, I'm sure, all of these topics. But Jane mentioned something that interested me, which was about the feeling tired at the end of the day. And it seems to me that this whole topic of listening efforts is something that's quite a hot topic at the moment. And for me, it was probably the best talk of BCIG this year, was all about listening effort and how to measure it. Do you feel that's changed how we offer rehab to people, sort of just even recognizing that this is more, I mean, I suspect you guys have known it for a very long time, but the fact it is recognized better now, do you think that's changed how we help people? Or should it?
It should. I think that it's always been recognised quite widely within the implant profession. I think it was a beautiful experiment that was described at the BCIG to prove something that we already knew, and that's what he was saying was, well, I know we all know this, right? But here's how I was able to prove it. It's I have cited it. I've been able to discuss that with families, and I know that my speech and language therapy colleagues have also. So I think we already knew about it. It hasn't greatly changed the way that we discuss it. We were always discussing it previously. We've just got different ways of being able to describe it. The challenges outside of implant centres and people who particularly are used to working with the hearing impaired, that knowledge is still not there, and it can be quite hard for people to get their heads around it. I think Jane gave a good example with the discourse tracking. I apologise, I can't quite remember what you called it.
Yeah, the text tracking.
As an example, and people, but I think even when you say, as I think the example Lise gave, I think it was Lise, if this child has a language age of 2 and they're in year 1 or reception, and that's why they're struggling, even when you understand that in theory, it's quite hard in practice when you see a child that does turn to their name or they are doing well. There's a gap between what we know and understand the ramifications of an issue to be and what the general population might, and in particular teachers and others interacting with children with deafness, hearing aids or cochlear implants. There's a gap that needs to be filled. So we know it, the families know it, the kids know it, but it's a hard thing to get your head around if you're not experienced.
Yeah, Angela, I guess it's something that you're very familiar with as well, and having to explain to people that about the importance of this issue.
Yeah, I think it's really important, but what is really difficult is each child is different, and you tend to get teachers in settings who'll say, well, so-and-so didn't need that, so why does this child need it? And I think it's also, what is an acceptable amount of time out for your listening efforts? So some parents have read up on it and go, oh, well, she comes in from school and she needs at least an hour and a half without her processors on because it's been such an effort listening at school. And then you go, well, do you put them back on after an hour and a half? Oh, well, sometimes, but if she doesn't want them, we don't bother. So it's that sort of getting a balance of accepting there is a listening effort issue, but how you quantify that and what you actually do to rectify that or ease that is a much more difficult situation to try and organise and explain to parents, particularly those that are struggling to get the processors on in the first place. It's a very easy situation that they can say, oh, well, they wanted them off because they're tired. When actually that yes, you could have had them off for 15 minutes or so, but let's put them back on. Or do they need them on when they're watching TV because they're not actually listening to it a lot of the time? Would they be better having that as their break and then coming back to it when they're sitting down at the dinner table when the conversation's flowing? I think it's a really tricky situation that has to be done on an individual level, but I think in settings it's really hard when they've got children with different levels of need, and that's where it's tricky in schools.
Please, can I come back to you? There's a topic, because we're already, believe it or not, running low on time, but I wanted to ask about auditory verbal therapy, and this perhaps ties in with what we were just talking about, the fact that children being encouraged to listen more and more and more, but obviously that's exhausting for them. What maybe is, because as a surgeon, my understanding of these things is obviously somewhat limited. What's the current thinking on sort of auditory verbal therapy, and is that now accepted to be the sort of best approach, or are we still?
Oh, I'm not answering that, Steve.
Okay, so perhaps I should.
I think it's as Andrew said, I think there are horses for courses. Of course, I'm going to say that I think auditory verbal therapy works because I'm an auditory verbal therapist and I invested some time and effort into getting qualified. But I don't think it works for everybody. I think it's about finding the approach that is appropriate for that individual. And so we're not an auditory verbal program, but we do use and incorporate auditory verbal into our rehab program. But there are some children where auditory verbal is not an appropriate approach for them. But I think for the right child, you can get spectacular outcomes from AVT. And I am very pro it.
Do you think it's something that most should be trained in or have access?
I think there should be more knowledge. Yes, I definitely think there should be more knowledge, because I think there are still an awful lot of misconceptions out there about what AV is. And so I think there should be more knowledge so that people realize it's not black magic, you know, and it's probably not that different from what is being done. There is good speech therapy practice out there. I have witnessed it. There is bad speech therapy practice out there. I have witnessed that as well. There is good AV practice out there, but there is also bad. It's about you take the theory and the science and then you apply it in the way that works with you and your personalities. And so, I mean, I think the main thing with AV that we are misunderstood about is that we deny lip patterns. We're not denying lip patterns. We're encouraging children to have the confidence that they can process information through the auditory channel when the listening environment allows them to do that. I would never expect a child not to have access to lip patterns in a noisy classroom. But if they're sat next to me in a quiet room and there's only me and mum with them, absolutely, I would expect them to be able to do that. So yeah, I think there should be more information about that, because I think we're very misunderstood.
Jane, do you have anything you'd like to add to that? And perhaps you can discuss that perhaps in context of children with additional needs and how you think that approach has to differ when you have a child with additional needs, which, as Lee said, is quite a significant proportion of this population.
I can't really talk about AVT with additional needs because we don't use AVT with additional needs. We use AV approaches incorporated into our best practice. So, I mean, I think Lisa is absolutely right. I think AVT is misunderstood, and I think when Warren Estabrooks first came over to the UK to talk about it, I was sat with a lot of teachers of the deaf in the room going, "We do that already," and they didn't, but they thought they did. So I think they haven't then spent the time to find out what is it about AVT that is the sort of not magic, as Lee says, but the approach that needs to be taken, which is slightly different, and it is only the difference, isn't it, Lisa, rather than a complete opposite. But in terms of children with additional needs, I think I can't really talk about that in that mix, because I look at children with additional needs, depending on what their additional needs are, quite differently.
I mean, that's
I would look at functional. I'd look at functional beyond all else.
How do you approach differently the child with additional needs is kind of what I was trying to segue seamlessly into.
I see. I missed that. Obviously,
no, sorry.
That sleight of hand. I think with children with additional needs, I would look very much at their functional needs, functional requirements, and they are quite individual. So, you might have a deaf child with visual impairment. So you're going to look quite differently at and discuss with their local support professionals and parents, because they know them best. So I would never, ever claim to be the expert with children like that. I think those that are the walking additional needs children, I think we do have a massive role. So those who've got maybe ASD or ADHD or disproportionate language impairment, particular learning difficulties, I think we have got more to say about that, but I don't think we've got time to do that. But I think I would definitely rely on those professionals that know much more about children with profound and multiple learning difficulties.
I think the take-home message there is the individualized approach, isn't it, really?
Yeah.
Andrew, would you agree with that?
Yeah, I totally agree with that, because I think the term additional needs covers so many different aspects that you can't have one approach that suits all of those. You've got to go with the child's individual needs and support them in the best way. And I think the sensory side of things is another thing that's coming much more to the fore, of looking at their sensory needs and how we meet their sensory needs.
And Mirette, anything you'd like to add on the additional needs sort of side?
On additional needs and possibly even more widely, I guess I would say that a multidisciplinary approach is quite important. So when you were asking about outcomes and what outcomes tools we use in audiology, it's fairly straightforward insofar as you want a good audiogram or a good speech discrimination, and there are a few different tools for that. But overall, what we're trying to do is to liaise with our colleagues at the Teacher of the Deaf and Speech and Language Therapy colleagues to inform when we've done something or made a change, that we would inform them, and that when they're spotting an issue, that they might inform us, and that is for all children, but particularly for those ones with additional needs. You want the best of your best practice in that regard, to be able to work as professionals and together with the family to scrutinise what might be a response for that child, what is the effect of that change, and it has to be, it often needs to be very focused and very well thought through and examined over a period of time, because the way that child, I guess adult also, is able to give feedback is not necessarily instantaneous. So for me, the joy of this profession has always been, being in implants, is the close multidisciplinary working for outcomes, for assessment, for every aspect of a child, a young person, an adult's life, where I get to do it, where I have had the opportunity to do it with adults as well. It's the field of cochlear implants. It works at its best when we work together.
That's a great note, perhaps, to start to draw things to a close. We're coming to the end of our time. And lots of topics I've got on my list here we haven't had time to get into. We haven't talked about psychology, which I appreciate is also an important part of rehab. So perhaps just to finish off, perhaps I, slightly tongue-in-cheek, just ask each of you very briefly, what would you advise as a surgeon? What's the best way I can help you in your rehab role? Or what would you say to a new surgeon coming in? What's the best way perhaps for someone to learn about rehab and what's involved with it? Just any piece of advice you'd give to a sort of a new surgeon coming in. How can they help you? How can they learn more? What would you sort of say? Lisa, I'll come to you because I know you can be quite forthright in these matters.
I don't know what you mean, Steve. I have no idea. I think I might say something similar to what I said to you. Oh, how many years ago was that? It's like, treat every patient as though it's your favourite granny, so that you always are looking after them at the best. I think coming and spending time, you know, how many surgeons have actually even come and seen a first programming? I suspect not that many. And the one piece, do you know what, actually, do you know the one piece of advice I'll give? Here's me being quiet and retiring and shy. Can you tell surgeons to stop standing up and presenting speech perception outcomes and language assessment outcomes and talking about outcomes that they don't understand? Ask their speech therapist and their audiologist to do it.
I think that's a very good note to give you that last word. And Angela, any thoughts along those lines?
I think the key thing I would say is the terminology that you use with parents when they're in clinic. You use lots of acronyms and things like that, which are so meaningful to you, but for the parents that are coming in with that new baby who's only just been diagnosed and they've been told they may need an implant, you talk at a level sometimes that's somewhere up there and you use acronyms that mean nothing. I think it's just think about this, how that parent's coming to that initial meeting. They're coming worried, upset, and without the linguistic knowledge of the terminology you're going to use.
That's really interesting. Thank you. And Jane?
Oh gosh, I mean, you don't often see,
yeah, nothing to add to what surgeons, you know, I'm sure they're all.
No, I think for me, I think for me, what Mirette was saying about the multidisciplinary meetings that we have every month, they tend to be focused on the assessment patients, and what we really need to build in is more feedback about what's happened to those patients and where are they now, and any issues that we've had, and make time for that and listen to the people who are working with post-implant patients.
Great, thank you. And then Mirette, perhaps final word to you on this subject.
I think that that Jane and Angela and Lisa have all given some really good points there. I couldn't disagree with any of those. I guess I would go back to the multidisciplinary aspect of what we do. And different teams have slightly different models, with the surgeons carrying slightly different levels of clout, perhaps. But for a new surgeon, I would say, just don't forget that everybody has something to contribute, that there are people in the team that will have years and years and years of experience and knowledge, and listen to them. Obviously, the buck kind of stops with you medically, but we have, once the implant is in, there is a lifetime commitment to that person, to that recipient, from the rest of the team. So even if you don't see them again, we have to carry on. We have to pick up the piece of anything that doesn't quite work. And in some of my best clinical, medical, MDT experiences, I've been in a room where a surgeon has deferred to me to give an opinion on some things that I don't know about this, ask Mirette. And that was, I think, empowering for everybody in the room, because it builds confidence and trust in the team. So don't bluff it if you don't know.
No, that's great advice, and certainly something I try to do.
Can I just add one thing that I think sometimes as well for surgeons, that it is about listening to the whole team, because just because you can doesn't mean you should. And I think surgeons sometimes it's like, but I've got a scalpel and I know how I can fix this. And sometimes sometimes sort of taking the whole team's opinion. The hardest MDT discussions are the MDT discussions where you decide not to offer an implant. They're the hardest ones. And I think sometimes there is a little bit from surgeons, there's this desire, because I think they don't understand the whole impact and what happens afterwards, and picking up the pieces and how it's not likely to be very good. And there is this desire to fix it.
Yeah.
So young surgeons learning that sometimes the best way to fix it is by doing nothing.
Yeah. Again, I think that's a great note to draw things to a close on. Thank you very much. And I think it's clear that, again, the take-home message is to all work as a team and value each other's opinions. And I think you've all given some really interesting, insightful comments this afternoon. So thank you very much for that. I'm sure we could go on a lot longer talking about all these topics and others. But I guess it's time to draw it to a close. So thank you very much. Thank you to Helen Peebles for helping the organisation of the session, and to Helen Cullington for introducing all of us. And I hope everyone has a really nice afternoon. Take care. Thanks very much. Bye now.
Thank you. Bye.